Thank you very much, Kieran, and thank you, Dolores, and to the Institute of Food and Health in UCD, and particularly to Afric for the invitation to speak at today's meeting, which I'm delighted to do. So I think on the bill, my talk is referring to vitamin D during the life course, but of course, I'm really going to be talking about vitamin D in pregnancy and early life, and asking the question, where should we go from here? So as previously mentioned, I am very interested in the feedback and the questions and answers in relation to this session, and we'll have our question and answer session this afternoon at 3 o'clock, I think. So without further ado, as Dolores referred to, we have very well-established roles for vitamin D in maintaining calcium homeostasis and calcium absorption, and obviously this has a massive impact on bone health throughout the life course in terms of bone development from the intrauterine stage throughout childhood, and then in later life, maintaining bone integrity and prevention of metabolic bone disease. But we also know that because of the unique situation which has emerged where you have vitamin D receptors in almost every cell and tissue of the body, but the more recent finding that the machinery for the conversion of vitamin D to its active form, 1,25 dihydroxy vitamin D or calcitriol, is available in almost every cell, which means that if sufficient 25-hydroxy-D is circulating, that means that paracrine production of 1,25 dihydroxy-D enables individual cells and tissues to exert non-genomic effects of vitamin D. And this includes, pancreatic effects, and this is why there's a huge interest in the role of vitamin D in glucose homeostasis, its immune effects in terms of its regulation of cytokines, but also immunomodulatory effects on anti-infection and cathelicidin production in relation to kidney function, which has a role in hypertension, and in relation to brain growth and development, which is probably a little bit earlier in terms of its development, a little bit more immature in the literature, but also some very interesting preclinical results coming out there. I'll refer to this a little bit later on. Why is this really relevant in pregnancy? And I think when we consider pregnancy, one of the things that we have to consider from a health perspective is that pregnancy is a time of immense stress on the body, and where somebody has a predisposition towards pregnancy complications from a metabolic perspective, and I'm referring here to hypertension and gestational diabetes primarily, those are like early indicators of potential later risk. The problem is that they're exacerbated and can be exacerbated by vitamin D deficiency, and this is what we're going to talk about a little bit later on here. But of course, if you've got vitamin D deficiency that is, for instance, having an impact on fetal accumulation of nutrients and growth during pregnancy, this can have a long-term impact on child health later on in life. So just to recap, you'll know this, many of you who are at this meeting today, that we have a vitamin D problem. Why do we? Because in this northern latitude where we live in Ireland, I'm going to refer mainly to Irish data and Ireland for this talk because it's only 25 minutes and we can't do a full global perspective. We've got a very limited supply of sun. But also vitamin D is present naturally in very small quantities in very few foods, which are infrequently consumed by and large. So therefore, there is a supply deficit. And I'm talking about not only wintertime, and this is the west of Ireland in July, but I'm also talking about, to a large extent, summertime if the weather is inclement. And this is reflected in the changes in 25-hydroxy-D, which is the serum biomarker of vitamin D exposure. 25-hydroxy-D is not a marker of health effect, but it is a very good marker of vitamin D exposure because it includes both the contribution from the diet and the contribution from skin synthesis. So what you can see here is where we would have typically been told that the annual drop or the annual low point or nadir in 25-hydroxy-D in most countries occurs at the end of a long winter. That's not the case in Ireland. In fact, our vitamin D winter extends from October, I would say, all the way through to April. And this is just some 25-hydroxy-D data taken from one of our studies where you can see that the drop is occurring already by October, November, and doesn't come back to life again until we get our annual peak UV exposure, which is in June, in fact. And you can see it comes right back down again. So we've got a very, very brief window of opportunity. The green lines really refer to the target 25-hydroxy-D concentrations that I will be referring to in this talk. These 25-hydroxy-D targets are disputed globally. The individual target is normally set at around 50 nanomoles per litre. This is the US and EU target and is relevant to our conversation. However, in the UK and Ireland and in the US, we also refer to a target of 25 nanomoles per litre. And I think that we should conflate the 25 and 30 nanomole per litre thresholds together. I mean, this is within the limits of most analytical detection according to the data that are out there. So I will be referring to roughly 25 to 30 nanomoles per litre. 25 hydroxy-D levels below this really show increases in the risk of metabolic bone disease and, for instance, nutritional rickets in infants and later osteomalacia and osteoporosis in adults. But the 50 nanomole per litre threshold has been used for other health outcomes and is often referred to as vitamin D deficiency in the literature. So I'll stick to specifying the specific thresholds according to their 25D value. So when we're looking at target concentrations, I want to resolve initially at the start of the talk the fact that where most international recommendations are based on meeting target values based on bone health outcomes, and most individual targets is 50 nanomoles per litre, everyone agrees that the absolute minimum is 25 to 30 nanomoles per litre. I don't see anybody disagreeing. Very few people will say, oh yeah, you can safely go down to 15. I mean, that's really not really what's happening. So where I would like to start from is if everyone has a 25D above 25 nanomoles per litre, most people are above 50 nanomoles per litre. And just for further confusion, Americans tend to use nanograms per ml. 20 nanograms per ml is 50 nanomoles per litre. So now that we've got that all sorted, the relevance to this is because we've got in the audience people who are working from a public health perspective, which is the perspective that I come from, and we've got people who are working as well as clinicians. So from a public health perspective, if everybody is above 25, then most people are above 50, and we know this from the way the distributions change. But from an individual or clinical perspective, generally speaking, clinicians are looking to get their clients to a 25 target of 50 nanomoles per litre. How do you do it? Well, the intake values have been specified by various authorities over the last 10 years, really. Actually, the first major one was IOM in 2011, and the last major ones were SACN and EFSA in 2016. But in the meantime, other agencies also did this. And let's not go there in relation to what do we mean by a recommended dietary allowance or what do we mean by an estimated average requirement. If we refer to personal targets and group targets. So personal targets set by, for instance, SACN maintained everybody above 25 nanomoles per litre with an intake for everyone, not an average intake in the population, an average intake for everyone every day of 10 micrograms per day. EFSA went with an adequate intake value of 15 micrograms per day to keep everyone over 50. And the Institutes of Medicine 10 years ago had not gone for an adequate intake value because they said that there was plenty of evidence in order to set a safe intake or a recommended personal intake of 15 micrograms per day over 50. So there was reasonable, I suppose, evidence on which to base these values for, and all of these people are men, and I think that that's an important distinction to make because most of the data had been collected in males, but both for men and women, in fairness, in older age groups and in adult age groups, there were reasonable and good data in order to set these targets. Very little available on teenagers at that time, almost nothing on young children at that time, and the infant data was reasonably well agreed at that time. So I'll really focus on I'll be really focusing on those age groups where there isn't a huge amount of data. Together with my colleague Kevin Cashman in Cork, we had led a large consortium, an EU consortium called Odin, which was in and around the whole area of vitamin D requirements and fortification, which finished at the end of 2017. And one of our targets was to establish the evidence for setting vitamin D requirements, dietary vitamin D requirements for those age groups where and ethnic and life stage groups where evidence had previously been non-existent or very minimal for the previous round of DRV reports. So one of these was a dietary requirement for vitamin D in white children aged 4 to 8-year-olds. Another in Surrey was adolescents using the same study design. And we also did IPD analysis from previous RCTs, which challenged the notion that 10 or 15 micrograms per day might be enough to keep everyone at 15 nanomoles per litre. And what we found was 10 is plenty to keep 95% of the people above 25 nanomoles per litre. But if you're setting a target for the population or an individual target of 50 nanomoles per litre, you're much more likely to need something closer to 25 micrograms or 1,000 IUs per day. So I think that's the answer really for the childhood to older age white population. Vitamin D recommendations in young children are roughly the same as for older adults. But when we come to pregnancy, there was very, very little information at the time that the recommendations are being set. And basically what happened was that pregnancy was, there was an assumption that there was no difference during pregnancy or lactation. So pregnant women are being given the same recommendations as non-pregnant women. And on the basis of what? The other problem we have is that we've got very little information that specifies people of darker skin or of ethnic minority, and particularly taking into account children, adolescents, pregnant women, older adults, and right throughout the life stage, where skin color and ethnicity both have to be taken into consideration. And this has been borne out by a really nice dose response study carried out in Sweden, where children were assigned to dose response within a randomized control trial, asking the same type of question. And 6 and 14 micrograms per day were required to keep fair and dark skinned children over 30 nanomoles per litre, and 20 and 28 micrograms per day were required to keep fair and dark skinned children over 50 nanomoles per litre. So this shows that there is a very clear division based on skin colour and ethnicity, or ethnicity, in terms of the dietary requirement for vitamin D. And this has to be really addressed, because it is essentially pretty scandalous that there is very, very little data for non-white adults and children in this regard. But the question we're asking now is, where do we intervene? Do we look at women prior to pregnancy? Is it during pregnancy? Is it when they're small and they're just starting to go on to complementary foods? Is it when they're in their childhood? And there's a whole area of work that needs to be done in this brand new population amongst us, which is the area of preterm infants. So let's look very quickly at preschoolers, first of all. And I'm going to take each one very, very briefly. So Hayek et al. Over in Canada had realized that despite very low vitamin D intakes, the vitamin D status in Montreal preschoolers was actually quite good. And this was very much related to their intake of fortified milk. And in our case, and in European children, similarly, we did a comparison between various studies that have been carried out in the UK, in Germany, and in Greece, and in the Cork Baseline birth cohort study, which I'll show you in a moment, showing variable proportions of children with 25D values below these different thresholds, again, very much reflecting their background dietary intake. And also, I think it's very difficult at times to show this very accurately, because many studies don't take into account supplementation and fortification, and some of these hadn't. But I want to show you some data from one of our big studies in Cork, which is the Cork Baseline birth cohort study. Some of you may have seen some of these slides before, so I apologize for that. But in general, the point is that we followed prospectively 2,100 mothers from 15 weeks of gestation onwards. This project overall is being led by Deirdre Murray, who's the Professor of Pediatrics in UCC, and I'm the nutrition lead in the project. And so we followed babies prospectively up until the age of 5 years old, at 2 years, and at 5 years of age, and at 15 weeks of gestation. And in cord bloods, we had extensive, very careful biobanking of serum and plasma and whole blood samples. We also had dietary assessment at 2 years of age. And what we can show you, and at 742 blood samples at 2 years of age, this represents the largest prospective toddler study in Europe. And what we could see is that there was low vitamin D deficiency in these Irish toddlers. And the reason it's so unique is that they were all within 3 months of age of each other. So in this 742, which, you know, is representative according to the CAO statistics, we showed low vitamin D deficiency despite the northerly latitude, the fact that they're living in Cork, and the fact that they also had a high prevalence of inadequate intakes, because of course we had intake data with them. But if you looked at the entire cohort, only 1.6% were below 25 nanomoles per litre, although a quarter of them had a 25D value below 50 nanomoles per litre. We could see, of course, that there was an impact of things like vitamin D supplements and formula consumption, but mainly it was the intake of fortified food in the background, not just formula. And you can see that here. Sorry, I thought there was a little circle going around it. Now, one of the things that I thought was really interesting was when you looked at something like their vitamin D intake, microgram per kilogram of body weight, it shows that the intake per kilogram of body weight was an important factor. There's not a whole, I think there's a big difference between a 2-year-old and an 8-year-old. And currently the recommendations go from 1 to 10 years of age. And that's the point I'm making here. We have to consider small body size as well when we're looking at toddlers. We also have to consider that in terms of assessing their intakes. We shouldn't compare toddlers with 10-year-olds. So their intakes were reasonable if they were consuming fortified food, particularly if that food was milk, to be quite honest. At this age, their diets were determined by their milk intake. And this is also reflective in other studies that have been carried out. This study was carried out in Belgium, and what you could see again was that, you know, the proportion of food that was mandatorily or voluntarily fortified was a massive factor in determining the vitamin D intake, vitamin D status, and the proportion of individuals below various 25-hydroxy thresholds. Going to infancy, and you know, the key here with infancy is that we need to prevent nutritional rickets. That's the starting point. And we need to prevent the very profound impacts of vitamin D deficiency that can result in cardiomyopathy, which can result in cardiac failure, essentially, and mortality among infants. And there is some work being carried out in this area in Birmingham in the UK, because it is still a problem where people are not availing of Healthy Start supplements and not really understanding that children need to be given vitamin D supplementation from birth. And the resumption, or I suppose the increase in nutritional rickets globally, particularly among immigrant populations to countries of northerly latitude like Ireland or the UK or the north of Canada, for instance, has provoked this, you know, epidemiological data coming through that there is a resumption of nutritional rickets in many areas. And for this reason, a consensus workshop was convened by the European Society of Pediatric Endocrinology, and it was led by Professor Wolfgang Hogler. And this was a massive piece of work that I was honoured to participate in, where you had 33 scientists from around the world, either vitamin D experts, nutrition experts, pediatricians, obstetricians, lactation specialists, public health specialists, endocrinologists, and so on. So very multi-sectoral, multidisciplinary teams to conduct a series of 33 systematic reviews looking at very specified questions within various topics. So my role was to lead the nutrition topic, and the consensus was, even though there are not, you know, obviously very well conducted randomized controlled trials in this area, because these are mainly clinical cases that arise, and if they're reported, they might be reported as cases or case series. But that infant supplementation and complementary feeding should be as follows: that there should be an intake of 10 micrograms per day of vitamin D, complementary foods introduced no later than 26 weeks, and that these should include rich sources in calcium. And that beyond 12 months of age, all children and adults need to meet their nutritional requirement for vitamin D, which is at least 600 IUs per day or 15 micrograms in our money as per IOM. I have to say that before I go on, from an infant point of view, there is widespread agreement of this, and there's widespread agreement of it on the basis that a large number, sorry, there's a slide there that should be there, I apologize, that there's a large number of studies that have shown that 10 micrograms per day during infancy is entirely safe. The American Academy of Pediatrics and the Doseresponse study, which I thought was the slide that I wanted to put in here, by Sina Gallo, showed very clearly and distinctly that 10 micrograms per day was safe, and 10 micrograms per day in infancy brings 97.5% of babies up to the 50 nanomole per litre 25D threshold. But where are we in Ireland, and what happened with our cohort study? So when we had our 2,100 moms, we managed to follow 1,800 of those babies, and over 1,000 of those we managed to biobank cord serum from them. And when we're looking at this prospective cohort, it's important to remember the massive scope of the thing. The paper is down there, but there were over 10,000 assessments in the HRB Discovery Centre in UCC, where we did a huge amount of prospective data collection led by the specialist in their area. So whether it was a psychological assessment, a pediatric clinical assessment, a nutrition assessment, the leader in that area specified and validated those assessments, for instance, for childhood atopy or eczema. So where I was working on the infant side, we measured our 25-hydroxy-D, and this is the largest study globally of cord samples measured by gold standard mass spectrometry, and we could see that 35% of babies at birth had a 25D value below 25 nanomoles per litre, the lowest threshold, and 80% of them were below 50. But we didn't see any effects of maternal or cord D on infant or child outcomes, particularly from the perspective of brain, which we were very interested in, and which is very emerging as an area of interest from the vitamin D perspective. And this is a lovely paper from Wellcome Open Research that you can download for free and take a look at it. And what they had shown, what we had shown in a kind of a mini review and incorporating our own data, that there's been a lot of interest in the area, not a lot of massive quality of research from a clinical perspective in the area. And this was borne out by that Wellcome Open review, where they found that there was just too much disagreement and not enough prospective research to determine the impact of maternal and or neonatal cord vitamin D status at birth and neurological outcomes. But when we look at, where our health outcomes were going, we simply haven't seen any effects, long-term health effects of these very low vitamin D status at birth. And I was wondering, well, why is that? So we went back and looked at all of the individual data points. And because we'd followed the babies up to 5 years, the lifelong picture of vitamin D status shows that they have, 1 in 6 are vitamin D deficient at pregnancy, 1 in 2 are vitamin D deficient at birth. But by 2 years, we had less than 5%. And at 5 years, I haven't shown you the 5-year data in over 500 babies, but at 5 years, also very few of them had those very low thresholds of vitamin D deficiency. The question is about their diet around 2 years, but also when you look at adherence to the infant vitamin D policy in Ireland being very, very high. And the FSAI did an extremely good job, and the HSE did a good job of implementing the vitamin D policy in Ireland. Adherence is very high. Does this offset the risk of adverse effects? And this came from another prospective birth cohort, where we could see, if you look at the old project, pre-policy, very low vitamin D, baseline project, pre-policy, very low vitamin D uptake. Post-policy implementation, September 2010, high vitamin D supplementation. And then now, so much awareness in the population, massive vitamin D supplementation over the first year of life in the newer study, which finished in 2019. So I have about 2 minutes left, and I'm going to go very quickly through where we are with pregnancy. We know that pregnancy vitamin D metabolism is completely different to non-pregnant metabolism. You've got a very rapid increase in 1,25-dihydroxy vitamin D in the early stages of pregnancy. This may be to induce an immune tolerogenic environment and to maintain the pregnancy in those early stages. We also know from various systematic reviews that there's a very high prevalence of vitamin D deficiency around the world, and that the majority of this is borne by women of dark-skinned complexion. In Ireland, we have 1 in 6 women with a very high prevalence of vitamin D deficiency, 1 in 6 compared to our non-pregnant adult population of 1 in 8. And we know that this is complicated by the presence of obesity. We've got an increasing prevalence of obesity in our Dublin hospitals. But, should we have pregnancy-specific thresholds for vitamin D and pregnancy-specific thresholds that clinicians will ask their women to target, or that we should have, overall vitamin D supplementation policies? Thank you. So I'm going to wrap up in the next minute or so. So far, many systematic reviews have shown inconclusive data based on pretty poor trials. There are many different factors. This is an open access paper, many different factors affecting the clinical outcomes of those trials. But what we do know for sure is that a cord 25 hydroxy-D, the baby's vitamin D status is absolutely determined by maternal status, and that there is no other source for babies, and that they're born completely dependent on what has been transferred through the placenta. So could we ask the question, should maternal 25D and maternal vitamin D intake be sufficient to prevent low vitamin D status among newborns? And we did a trial to ask this question, dose response, in 48 women per arm. And what we could see is that when maternal 25 hydroxy-D was at 50 nanomoles per litre at term, 100% of cords were above 25. And the answer then was that 1200 IUs per day, or 30 micrograms, which would be a 25 microgram supplement in addition to the background diet, completely prevented neonatal vitamin D deficiency. This has been pretty much in agreement with a recent study carried out in the north by colleagues in the north, and you can see that there was a small impact of obesity on the final cord value here, but we didn't see that. So I think maternal obesity needs to be investigated in much greater detail, specifically with a much wider BMI range. We also need to consider the role of calcium. A huge number of the vitamin D RCTs are not considering the role of calcium, and what we're finding is where you have a very low calcium intake with a high PTH, that your impact on SGA and other outcomes is very profound. So take-home messages. There are plenty of data now from dose response RCTs to inform dietary recommendations for vitamin D intakes among infants, children and teens. Therefore, the current DRVs need to be revised. Further studies are required among preschool children and all dark skin population groups. White skin pregnant women require 30 micrograms per day to maintain 25D above 50, and this prevents vitamin D deficiency in newborns. There needs to be a simplicity of the messaging required as an initial step for implementation. My problem, I suppose, that I'd like to put to you, and in terms of your questions and in terms of your feedback, is why has there been a failure to translate this evidence, which is consistent in Ireland, in Canada, and in New Zealand, countries that have a huge amount of comparability in terms of background diets and latitude considerations. And when we're looking at our clinical guidelines and our public health guidelines, in order to translate the evidence accumulated over the past 15 years, and particularly in this country, and prevent vitamin D malnutrition on the island, we need a multi-actor national framework for vitamin D deficiency prevention, and it is a call to action at this point. I'd like to thank collaborators and funders, particularly Kevin Cashman in UCC, and thank you so much for listening.